Anesthesia in the ICU. Please join me in welcoming Dr. Iverson.
All righty, good morning. As you heard and see, I clearly took a winding road in my path to get here. I have no conflicts of interest or disclosures that are relevant to today's topic. Outlines and learning objectives, we're going to actually talk about the importance of patient satisfaction, and then we're going to touch on regional anesthetic and patient satisfaction, talk about a couple cases I had for regional options in different ICU patients, briefly mention single shot versus continuous catheters, and then there's actually new ASRA guidelines that just came out that you may or may not be aware of, where some of the terminology has changed and the timing for different anticoagulants and the procedures has changed as well, so we're going to just briefly touch through those. So for the impact of regional anesthetics on patient satisfaction and experience, and if you're like me, you're thinking patient satisfaction, why do I really care? The goal is to ideally get the patient through the procedure safely, but the answer to that is always money. And it's because reimbursement by Medicare is at least partially tied to patient satisfaction. And we know that commercial payers often take their cues from CMS. There's different surveys that are used, but the HCAP survey is the one that is the most common, and it's been around since about 2007. It's 32 questions. Unfortunately, none of those questions relate to perioperative care, and you will probably get this mailed to you anytime you encounter somebody from a hospital system. So if you have a doctor's appointment, if you go in to have a procedure or whatever, you're gonna get something that looks like this in the mail. And if you're like me, you just throw it away because it honestly takes too much effort to return back. But it breaks things down into four different sections. One is care from your nurses, there's a brief thing on care from your doctors, and then there's a whole part on the hospital environment itself. There's only 3 questions that ask about your care from your doctors, and you would think it would be care about how well did my doctor take care of me and did I do great through the procedure? No, it wants to know if your doctor treated you with courtesy and respect, did they listen carefully to you, and did they explain things in a way you can understand? That is how we're graded. And unfortunately, it's really hard to do all of those things and have meaningful outcomes when it's tied to money. So patient satisfaction in general is really hard to quantify, and it's largely because it's subjective. There's multiple things that are beyond our control. So for example, if we take the timing of a surgery, we know, for example, that a surgery that happens later in the date is associated with patient dissatisfaction. Now, if it happened to be that patient got added on urgently and the surgeon who's doing that is in the clinic in the morning, well, that surgeon may have moved heaven and earth and we may have bent over backwards to accommodate that patient getting in later as opposed to waiting a day or a week. But at the end of the day, surgeries later are associated with dissatisfaction, which means less money for us. If they've had prior anesthetics or healthcare biases, maybe they've had bad experiences in the past, they're much more likely to be unhappy having to come back through and have another procedure. Unrealistic expectations about pain and recovery. We all know that there are just some patients that want to go through a surgery and have zero pain. And then what the provider-patient relationship is before we're ever involved. So from a perioperative, things that are associated with improved patient satisfaction that we can directly impact. It's interesting. The first one is intuitive. It's sort of the quality of recovery. So patients obviously care about how their pain is going to be managed postoperatively, and also PONV. That would make sense. Having caregivers smile. So if you just see a patient in pre-op and you smile at them, introduce yourself to the family, smile, just take a second, that is associated with improved scores. Playing music is associated with higher scores. I do know that there are some attendings that not only play music, that they sing to their patients as well. And then lastly, interestingly, informing your patients about the billing process. Now I put some question marks up here because I work in academics and I'm lucky enough to not have to do anything with billing. I click anesthesia stop and then I click the things that I've used that are billable to the patients. I have absolutely no idea about billing. However, informing your patients about the billing process is apparently associated with improved patient satisfaction. So when we talk about regional anesthetics, we know that there are higher satisfaction scores from patients when regional anesthetics are used. And this is largely because there's better pain control and a longer duration of them being pain-free. Less opiates are needed and subsequently less opiate side effects. And as such, there's a shorter time in the hospital. Historically, compared with general anesthetics, neuraxial is associated with a reduction in mortality, morbidity, and things like length of stay, which can have significant economic outcomes. Opiates have been around for millennia. They actually found fossilized poppy seeds and evidence of opium about 30,000 BC, so this is not new. Medicinally, it's been used since about 4,000 BC, and up until the last couple hundred years or so, we were using morphine even to treat things like diarrhea. So we were taking advantage of the pain aspects of it, but also using the side effects to treat other ailments that people had. There's obviously different receptors that we're all pretty familiar with, so we're not going to belabor that. Benefits of regional in general. It's often safer than general anesthesia, and that's true especially in the high-risk patient population. So if you think back to your OB patients, most of us tend to prefer spinals as opposed to going general if a section is needed. Less opiate use means less respiratory depression. As an ICU doctor, as a pulmonologist, that's one of the things that I worry about. You heard that in our previous talks. There are just some patients who, underlying when they hit the door, I know as the intensivist, I'm going to have problems extubating them. Encephalopathy and delirium is actually associated with increased not only morbidity, but mortality. And so anything we can do to lessen those chances is going to be beneficial. Less hypotension, bradycardia, nausea, vomiting, so less aspiration risk. And then from a GI standpoint, less constipation and ileus. So in general, the less opiate use, the faster your patient's going to recover. They're going to get out of bed sooner, work with therapies like PT and OT. And if you're at an ASC, they're going to get home sooner. So regional anesthetics for anticipated ICU patients, or just ICU patients in general, there's not very many studies that look at this solely in the ICU patient population, but this is a study that was a prospective study. And they took 200 patients that were all going to go to the ICU post-procedure. And that's regardless of the procedure that they had or regardless of the comorbidities. These patients were anticipated and they were going to go to the unit even when things went perfect. And it spanned multiple subspecialties from a surgical standpoint. And of the three groups, they had one group that was solely general. They got no regional anesthetic. They had one group that was regional only, so surgical blocks. And then they had one group that was a combined regional with general. And what they found is, as a primary measure, anytime regional anesthetic was used, there was less ICU length of stays, ventilator durations were less, and complications like infection and delirium were less. And regional anesthetic were then noted to be an independent predictor of improved ICU outcomes. So when we talk about responses to pain, pain obviously activates the sympathetic nervous system, so that fight or flight system that we're all used to. From a cardiovascular standpoint, that's good. If I'm in some fight or flight situation running from a bear, I want my heart rate, my blood pressure to go up. I want that cardiac output to provide me with the tools necessary to get away from whatever it is that I'm fleeing from. Unfortunately, because the myocardial oxygen consumption is also going to go up, if I have patients in the ICU that have critical flow limiting lesions, this is where we will often start to see supply and demand mismatch. And so these are people that will come in with your type 2 MIs, what we call demand ischemia. And so pain in the ICU patients specifically sometimes will cause secondary issues. From a pulmonary standpoint, especially if there is pain in the thoracic area, hypoxemia and subsequently decrease in tidal volumes, FRC, vital capacity, especially from splinting respirations, can cause significant issues. When we look at respiratory complications, specifically in thoracic and abdominal surgeries, there's an increased mortality that's associated with respiratory complications. GI-wise, Activation of the sympathetics will lead to decreased GI motility, subsequently constipation and ileus, and that's regardless of the opiates that you use. Neuroendocrine-wise, we have increase in free fatty acids, hyperglycemia, and decreased immune response can predispose to infection. The renin-angiotensin system becomes activated. So there's a lot of things that happen in response to pain. Unfortunately, pain in the ICU is a reality. And they've done studies on people who survived their ICU stay and found that in addition to psychological consequences like PTSD, which is very real after they get out of the ICU, pain was one of the biggest complaints. Some of this stems from procedures that are needed, whether it's lines and tubes, drains that have to be placed, whether it's repeated trips to the OR for whatever reason. Some of it is just in nursing cares, so wound vac changes, dressing changes, just rolling and bathing the patient can hurt. Ventilator support, whether it's invasive or non-invasive, is pretty uncomfortable. And then just laying in bed, being immobile can hurt. And so again, increased ventilator stays, length of stays can predispose and have long-term morbidity consequences for things like PTSD and depression. So when we talk about regional options for patients in the ICU, a lot of this is going to be dependent upon what it is that you're trying to fix and what the patient characteristics look like, so what their comorbidities are. I like to know what the current issues are. If there's respiratory failure and I can do something to improve the respiratory mechanics, that's great, but I also need to be aware of the hematological abnormalities that may exist, whether it's pharmacological or other coagulopathies, and then hemodynamic issues. So we're gonna move into a couple cases. This was a 67-year-old male who presented with chest pain. History was significant for hypertension, hyperlipidemia only. EKG on arrival showed an anterior STEMI. I apologize if the gray doesn't show up. I don't know why it didn't print pink like his other one did. Shortly after arrival in the ER, though cath lab was activated, he had a witness cardiac arrest. And for about an hour, actually, would have ROSC and then subsequently rearrest. But total downtime where CPR was actively being done was a little more than 30 minutes. Ultimately, he ended up with PCI to the LAD, and we left him intubated after the cath lab to let him settle out in the ICU. Unfortunately, it was noted, I was on service, and it was noted that every time I tried to wake him up and lessen sedation to start getting neurological exams, he would go back into VT. And these VT episodes were just refractory, and he started having what we call VT storms. Had him on amiodarone drips, ultimately lidocaine drips, and subsequently procainamide drips. Flecainide, maxillatine were also added. And between interventional cardiology and EP cardiology and myself, we were sort of running out of options. And after about 4 or 5 days, I still did not have a neurological exam. Started looping in my CT surgery colleagues to talk about options that we could use if a mechanical support device such as VA ECMO could be used so I could actually support him through this while I stopped the sedation. Nobody was really keen, myself included, on putting this guy on ECMO when I didn't have a neurological exam, because if he didn't have a favorable outcome, now I've got a bridge to nowhere. And so talked to one of my partners, and ultimately we tried to do bilateral stellate ganglion blocks. And we knew it was kind of risky to talk to the family because he was on lidocaine and was on procainamide. But ultimately risk and benefit were discussed, and we proceeded with bilateral stellate ganglion blocks. His arrhythmias actually stopped pretty quickly, and though they stopped within the hour, I was pretty slow at weaning sedation because I wasn't quite sure it was going to work as well as it did, but actually he was awake following commands and extubated by the time I left that day. So the stellate ganglion, just briefly, was a cluster of sympathetic nerves at about the C6 area, anterior lateral neck, provides a sympathetic innervation to the heart, and so when you block it, you will reduce things like ventricular arrhythmias. Anticipated complications, as you heard by my previous speakers, if you do this correctly, you will get Horner syndrome. Other possible complications: vascular injuries, CSF injections, mediastinitis or mediastinal things if you have esophageal or tracheal injuries, and pneumothoraces can happen, but with experienced people using ultrasound, the risk is less. As you would imagine, VT storms are not terribly common, so there are no large, robust, randomized, double-blinded, placebo-controlled trials. However, one of the largest trials actually comes from the STAR study, or the STAR trial, which was a prospective study that occurred in Europe, and it was multi-countries over several years, and they looked at the effectiveness of stellate ganglion blocks for refractory VT storms, and they found that there was a reduction in arrhythmias in more than 90% of patients who had this within about 12 hours. And there's multiple US studies that support its use as well. So are there other possible applications of a stellate ganglion block? Maybe. Interestingly, this is not yet in US guidelines, and it may not come to US guidelines, but there are currently a lot of trials ongoing. When we talk about aneurysmal subarachnoid hemorrhages, this is classically what we talk about as far as the thunderclap headache or the worst headache of someone's life. And the mortality is really high, and more than 30% of people dying either prior to arrival or shortly after arrival. And of the people that survive, morbidity is really high. One of the things that we worry about the most is delayed cerebral ischemia or vasospasm. And this can actually occur up to 21 days later. The mainstay of treatment is just supportive care, but nimodipine is a calcium channel blocker that's actually started when patients arrive with a subarachnoid, and it's continued for 21 days. As you would imagine, a calcium channel blocker can have some hemodynamic effects. Doesn't matter if your patient is hypotensive, I will put them on an inotrope and they will continue on nimodipine regardless of blood pressure issues and things that I have to titrate to make it acceptable. And that's because nimodipine actually has some morbidity and some improvement in long-term functional outcomes. However, despite this, some people will still have vasospasm, and those are the people that historically end up dying a week, 2 weeks, 3 weeks after this. And so in other countries, they're using stellate ganglion blocks to help improve cerebral blood flow. And actually, the first study that I found, or the first paper that I found talking about improved blood flow with a stellate ganglion block was from the 1930s, so almost 100 years ago. In France, there was a surgeon who wrote about stellate ganglion blood flow as an adjunct to treat hemiplegia in his postoperative patients. Like I said, it's not currently in US guidelines, but there are multiple US trials that are going on. And so there is more data to come from this in the coming months and years, I would imagine. Case number 2, kind of changing gears. This was a 51-year-old male who presented with dyspnea, orthostasis, and just generalized weakness, not feeling well for several weeks. His history was significant for hypertension, hyperlipidemia, and well-controlled HIV. His viral load was actually undetectable, and CD4 count was normal. He did have pulmonary arterial hypertension related to his HIV, but he was very compliant with meds and treatment. He had been dialysis dependent for about 4 years. However, he was pretty reluctant to have any what he deemed unnecessary procedures, and so despite his fistulas being very aneurysmal, he had no desire to have these revised. And I do apologize, he did not consent to me taking a picture of his arm, so this was a representative image from an NEJM article, but his arm looked just like this. Labs and vitals on admission. Vitals were okay. It was a little tacky. It was a little hypoxemic and dyspneic on admission. Only admission lab that was noteworthy was a BNP that was greater than 5,000. And his tropes were negative. Chest x-ray showed pulmonary edema and pleural effusions, and he had been compliant with dialysis and was actually at his dry weight. He was admitted to the tele floor. He self-elected to be DNR, DNI, and was pretty firm in that. Nephrology was consulted, and our hospitalists were taking care of him for several days. He had repeated runs of intermittent dialysis, and they were pulling pretty hard, thinking he was just volume overloaded. Perhaps they needed to adjust his dry weight. And despite being 2 kilos below his dry weight, he continued to have worsening oxygenation and now new hypotension, prompting his transfer to me. We saw him in the ICU, confirmed his DNR, DNI status, for which he was pretty fixated. And so he had a long course for several days, for about a week, where we weren't making much progress. Maybe I was losing a little bit of ground. He was needing more and more inotropic support, despite me putting him on CVVHD, pulling pretty hard. Echo had no new wall motion abnormalities. We had started him on empiric antibiotics, thinking perhaps he was infected. Those were tapered off as labs and his physical continued to support that it was not likely to be infectious. Interestingly, on his TTE, though his EF was preserved, his PASP was now more than 100, and he had severe RV dilation and both moderate PR and TR. Imaging, including a new chest x-ray when he came to me, still had pulmonary edema. A couple days later, we got a CTA, thinking maybe there was a PE. There was no PE, but again, edema and effusions. I pulled pretty hard on CVV. Got him about 6 kilos, now below his dry weight. Repeated TTEs still continue to be unchanged. So I forced my cardiology colleagues into a right heart cath, whereas mean PAP after diuresis and the CVV still had a PAP of about 63. His cardiac output was 10 with an index of 5. When they manually compressed, because I was worried about high output failure, when we manually compressed, his mean PAP dropped from 63 to 39 on the Swan. And as such, the diagnosis of high output heart failure was made, and this was because of his aneurysmal AVF. As I said, he was very firm that he was not going to go full code at all. So conversations were had because we had to get this ligated. He was still pretty sick and hypoxemic. We went to the OR. He went down on high flow, 80 liters, 100%, a lot of inotropic support. Head of the bed was elevated, and he had a surgical block. And he was able to get this ligated with no sedation. Postoperatively, he did well and transferred out of the unit a couple days later. The last and final case was an 86-year-old male who presented the ER after falling down some basement steps. Good, bad, or other, I live in the Midwest and we have tornadoes, and this poor gentleman was evacuating when we had a tornado that went through our city. His history was significant for hypertension, AFib, recurrent PEs, and DVTs, and he was on Eliquis baseline for this, or apixaban baseline for this. He did have ischemic cardiomyopathy with a STEMI about 6 months prior, and his EF was about 10 to 15%. Had been on clopidogrel with his Eliquis, and then after the 6 months change, the clopidogrel stopped and he was switched to aspirin about 2 weeks prior. And unfortunately, when the clopidogrel stopped, he had an instant thrombosis. And subsequently now, after a new PCI 2 weeks ago, is back on triple therapy. So clopidogrel, aspirin, and Eliquis, or apixaban. Imaging in the ER did a small subdural. Most noteworthy, he had multiple rib fractures bilaterally. He was given PCC to reverse the apixaban because of the head bleed. Platelet transfusions and Rotem were used to guide transfusions to reverse his clopidogrel. He was admitted to the trauma service, and cardiology was ultimately consulted because we were sort of in this rock and hard place between his subdural with his ischemic cardiomyopathy and his now instant thrombosis. And as such, they had recommended aspirin and IV cangrelor, which you may or may not be familiar with. It's an antiplatelet agent, very short half-life of about 3 minutes, 3 to 5 minutes. And so much like Esmolol, it's kind of a rapid on, rapid off. And so that was recommended with repeat imaging to see if his subdural was expanding. His family and he had both elected to be DNR, DNI. Again, just given his age and comorbidities, that was reasonable. Over the course of several days, his rib fractures really became the paramount thing that we were battling. Worsening atelectasis and pain. Narcotics were tried after failing conservative measures, and then he became delirious as expected and as feared, and this made neurological exams difficult, and he was very intolerant of CPAP or any sort of positive pressure due to agitation. And so our pain colleagues were again consulted, and a rector spinae catheter was placed, and he was started on bupivacaine infusion for several days. This actually allowed for mental status and respiratory status to improve because he no longer needed anything that was mood altering. So we talked a little bit about erector spinae in our last conversation, or our last presentation. Just to remind everyone, it's a group of muscles that are used for stabilization. They're parallel to the spine, sort of skull to pelvis, and then SP to TP extending into the ribs. You saw some Nisora images, and then more importantly, you had a model up here with live demonstration. The benefit of the erector spinae in this situation was that for patients who had contraindications, in this case, this guy's antiplatelet agent, we couldn't do neuraxial, erector spinae catheter was a good option for him. The choice between a single shot versus a catheter in our practice largely depends upon what it is that you're trying to treat or what your anticipated duration is needing to be. And so there are no real guidelines. A lot of it is your clinical judgment. These are things that we do every day. His rib fractures weren't going to get better with a single shot, so catheters were left, whereas the surgical block for the fistula ligation didn't need a catheter, just a one shot and done. ASRA guidelines, you may or may not be aware of, have actually changed in the last couple of months. And so couple things, there's now terminology change. They no longer use prophylactic doses and therapeutic doses. They are now calling things low dose and high dose. Lab monitoring is recommended if possible. If your DOACs have levels at your institution that can be measured, they should be measured. Ideally, a level less than 30 nanograms per milliliter tells you that your patient is not anticoagulated, which means needle is okay. Anti-10A levels, DTT, so thrombin time levels, INR, things like that should be measured if at all possible. Additionally, specific reversal for anticoagulation is not recommended if you're trying to do it to perform a block. So if, for example, your patient is coming in and he or she is on a Pixaban, you don't have to reverse with PCC or Annexant. They're just asking that you wait and hold off as opposed to fully reversing them. Again, assuming that time allows and the surgeon allows. Procedural timing, the drug half-life, is now what's going to be used to guide whether or not you start or continue going into surgery. So historically, we've said, hold X drug for 72 hours beforehand. It's now going to be based off of the half-life of the drug. If you're doing a neuraxial or a deep plexus block, if your patient is on a low dose or historically what we've called a prophylactic dose, you want to stop it more than 2 half-lives of the drug. If they're on a high dose, you want to stop it now more than 5 half-lives of the drug. Additionally, you want to take patient considerations into play. So if your patient has renal failure, you're going to add additional time in for that. If your patient is on additional medications, which may also have some coagulopathy, so Pleadal or Celastazol, for example, like an old anti-PAD medication, they're recommending, for example, that you hold it for 120 hours. And so there are new guidelines, and these are all completely free, available to download. You don't have to subscribe to anything. You can just Google search it, and they will pull up for you. I found this. I don't know who this gentleman or lady is, but kudos to them. Their name is at the bottom of this. It just broke things down into the test that you should use, how soon before you should stop and after catheter, and then when to remove after regional. In conclusion, pain has multiple physiological consequences and prolonged or long-term potential morbidity in the forms of PTSD. Patients are unfortunately at the top of the line for the uncontrolled pain. Regional does have applications outside of the OR or outside of the normal perioperative patient. Single shots versus infusions or boluses can be considered, and then ASRA guidelines are now free. Any questions? Yes, ma'am. So the question was, are bilateral better from a literature standpoint as compared to unilateral? I think the jury is still out on that. Several papers had decent data with a unilateral. More papers showed better efficacy with bilateral. And in the case of my patient, because we were now at day 6, when we actually did this, we elected to go with bilateral, knowing that we were actually pushing the doses of our local from a max dose standpoint. So bilateral is what we opted to do. We have done unilateral in my institution in some of the ICU patients that I've taken care of, again, for VT storms. And most of the time, my VT patients, I can get controlled with IV meds alone. And so I know in my institution that I've been involved in, I think I've had 3 what we've done bilateral, but the majority have been unilateral. Usually left side is what we'll do. Other questions? Are you coming up here for questions, or can I run? Oh,
Questions, yes.
so close.
So we're actually going to invite Dr. Rubin and Dr. Goldberg, if they're in here, back up to stage so you guys can ask questions. I ask you to come to the microphone if you do, just so that everyone can hear the questions. And as they're walking up, my question for all 3 of you is, what are your limits for ESP, if any, in terms of anticoagulation? Let's say a patient with liver failure, elevated INR, or if they're just on anticoagulations, at what point will you guys not perform that block?
Personally, I don't avoid rector spinae blocks due solely to anticoagulation. I do consider that a peripheral block, so I don't really look at the coagulation profile in doing that. In the case of somebody with liver failure, if I think that their liver failure is severe enough that it would hamper their ability to metabolize the local anesthetic, that might be a situation where I avoid doing.
Is this, and then also, what are your concerns when you do these deep blocks? So when you do an epidural, your concern is you get epidural hematoma in a very small space, so that's a concern. With an ESP, with a paravertebral, for it to crack back into the intervertebral foramen and then cause some sort of epidural hematoma is very unlikely. Your bigger concern would be you get a bleed that's non-compressible and you continue to get a hemoglobin drop. So for some of these deeper blocks, your concern is nerve damage. For some of these blocks, your concern is larger bleeds.
And same. As he said, we consider this to be a peripheral block. And so anything is a risk and a benefit. At the end of the day, you have a non-compressible bleed. But in the case of our patient, a guy who is on aspirin and cangrelor, who's had instant thrombosis, it's not ideal. And there was conversations and explicit consents done with the family. But honestly, the guy was dying from respiratory failure. And so the thought was anything that we could do to lessen agitation and improve respiratory hemodynamics was what we were willing to try.
Thank you. Dr. Iverson, you made a point at the end about explicitly not reversing anticoagulation to do blocks, but then also hedged with if time allows. And I guess the question would be, for considering a block as potentially life-saving, I suspect that changes that safety profile a little bit, reversing anticoagulation in order to do a block, which is not otherwise recommended. I don't know if any of you would speak to that.
So interestingly, I'm not going to lie to you. In my institution and for myself personally, if I have a patient who's coming down to the ER, theoretically, they should not be anticoagulated, right? If we're going to have a surgery, for the most part, they're not anticoagulated. I actually thought it was interesting that that is now one of the new guidelines in there, that they specifically say don't reverse pharmacologically. But to your point, absolutely, yes. If I don't have to wait, then I don't have 3 days to wait, and we'll reverse if we need to. In the case of the gentleman that I had on cangrelor, we actually timed it to where his dose of cangrelor was running out. It was going to be a couple minutes, and so I just said, you know what, we'll get the needle in really quick as the next dose is coming from pharmacy, that sort of thing. The half-life is short enough, but at the end of the day, if we needed to reverse for something that's life-saving, I need to reverse. Probably not the guideline answer, though.
Any other
questions for Dr. Iverson? Guy Williams from Omaha Children's Hospital. I really appreciate you mentioning about patient satisfaction. And a lot of times, I think all of us face opportunities in emergency situations when obtaining information to lessen the risk of anesthesia can sometimes seem difficult for the patients to answer, or they might not have adequate information. And despite being courteous and informative and being respectful, there's still some times that the patients feel out of place or question too much. But I appreciate you bringing it to our attention again, because I think there's many opportunities to improve our interaction with the family during this high stress period. And I don't think we hear that very often. We're discussing regional anesthesia blocks, and your patients, particularly in the ICU, are under great stress, fear of their loss of their life. And in some ways, in families with maybe a mother with a child in the emergency room late at night, they're fearful also for the same outcome, not knowing maybe with an unknown past medical history of malignant hyperthermia or some type of enzyme deficiency that they're not aware of. But I appreciate you mentioning that.
Thank you.
All right, I have one more. So in the first presentation, paravertebral versus ESP, paravertebral is better in almost every instance except if we're dealing with anticoagulation. And this question can go for all three of you. What surgeries or what factors make you choose an ESP over a paravertebral? If, you know, all factors being equal, you can do either.
So as far as I'll break it into two. So one is provider specific and one is surgery specific. So provider specific, I view it as a spectrum of how comfortable are you performing these. So if you're teaching residents, certainly if the ESP, anytime you have a bony backstop like an ESP block, it tends to be a little bit easier because you're going for a target as, you know, if you go too far, you stop at the TP as opposed to you go too far, you're now in the lung. If you're still learning or if you just want to take anatomy out of the picture, doing an ESP is fine. From a surgical standpoint, spine surgery is a good example of where I consider paravertebral and ESPs as more comparable, because what you're going for, your target, what you're trying to anesthetize, is the dorsal ramus of the spinal nerve, which goes through the ESP muscle to the back. So the ESP is really good at getting that, because even if you don't go through the thoracolumbar fascia when you hit the TP, you're still going to anesthetize that dorsal ramus. So paravertebral and ESP are both very good for spine surgery. Anything on the abdominal wall, I think you're going to get more reliable coverage with a paravertebral block. So that's kind of how I would separate those.
It's a pretty specific surgical indication that I tend to prefer an ESP for, is large liver resections or a living donor from that pair. And that's just because I've seen plenty of times where if you take an entire lobe of the liver or you take a large section of liver, immediately afterwards you may have a pretty dramatic rise in R, coagulation issues or hypotension afterwards that should be typically lessened with an ESP. So you can have instances rather than an epidural or a paravertebral where you do bilateral erector spinae catheters. And the analgesia might not be as reliably good. It might be, if you're talking about 70% of what you could get with a paravertebral or an epidural, but I'll take that as long as the clinical safety profile is better.
Anything to add, Dr. Iverson?
Nope.
All right. Any other questions? Yes.
Jessica from Omaha. One of the things that I've noted in the ICU and for other pain management considerations is the increase in the blood flow from the sympathectomy that you get from it. And so how often have you seen or performed blocks because somebody has necrosis in their digits and they're having difficulty with pain as that is being worked through? We've seen that in peds for some things. There was a penile surgery. They wanted a caudal so that they wouldn't have any complications. It dilated everything. It looked great. Same thing if a little baby has gangrene and they're unable to extubate them because the pain is just so bad. So doing a block or a catheter might be helpful. Have you seen that type of treatment approach?
Scleroderma and Raynaud's, where people come in with a very powerful vasoconstriction in a upper extremity, has been an indication that we've done blocks for with catheters on our acute pain service. We do them pretty routinely for the surgical care of AV fistulas just because of the vasodilation that occurs. Helps surgically, gives them better vasculature to work with, and then there's also improved maturation of the grafts afterwards. So it's a pretty frequent indication for us.
We actually don't, at least in the adult population, it has not been anything that our institution has utilized. So I'm not as familiar with that. Conceptually, it makes sense, but it's not anything that we practice or we do.
Yeah, it's always interesting at our institution. We'll block the fistulas like he was saying, but our surgeons are slow. We'll still put them to sleep because the patient can't lay there for 6 hours while they're trying to sew. Any other questions? No? All right. Well, thank you, everyone. Join me in a round of applause for our speaker.